All right, so welcome everyone to our weekly Wednesday morning UCSF Orthopedic Surgery Grand Rounds. Today we have the honor of one of our own faculty members presenting, and for an introduction, I'll turn it over to Dr. Coughlin.
Good morning, everyone. When Drew asked me this week if I'd want to introduce the Grand Round speaker, I immediately thought that I would have a really tough act to follow from Sam Morshed's effusive introduction of Steve Benershka last week. Then I quickly thought, well, how do I do justice to a true giant of orthopedic surgery and a name that's recognized around the world for his preeminence in the subspecialty of foot and ankle surgery? So I thought I'd keep it simple. For his pioneering work, lifelong contributions, his mastery and advancement of Gait, biomechanics, his leadership, straightforward educational effort, Dr. Roger A. Mann is the GOAT of foot and ankle surgery, the greatest of all time. So Roger was born and raised in San Francisco. He attended University of California, Berkeley for undergraduate work. He followed with medical school and orthopedic residency at the University of California, San Francisco. So clearly he's one of the greats to emerge from our system. Early on, Dr. Mann worked very closely with Vern Inman in the Biomechanics laboratory at UCSF, publishing seminal articles for which we'll get some knowledge and wisdom in today's talk. His clinical practice began in Oakland. Dr. Mann started one of the earliest foot and ankle fellowships in 1979, now having trained well over 79 fellows. The Roger A. Mann Award was established in 1994 to recognize the best clinical paper at the American Orthopaedic Foot and Ankle Society, the society that he served as president, along with decades-long leadership of the board. Dr. Mann has over 150 published articles, 30 book chapters, has been the editor of Mann's Surgery of the Foot, the most worldwide recognized and utilized educational tome on the subject. Most recently, he was successful for being the lead investigator of the STAR ankle prosthesis through the grueling FDA process. We're indeed fortunate, honored, and privileged to have Dr. Roger A. Mann as professor within our Department of Orthopedic Surgery, providing inspirational achievement and brilliance. We look forward to hearing his talk today.
Good morning. Thank you for that lovely introduction, Rick. Let me click the button here. Okay, going to talk about biomechanics of walking. I became interested in biomechanics after I heard the first lecture by Dr. Vern Inman, who, as Rick said, was the previous chairman of the department back in the 50s and 60s. He was a very dynamic speaker. I heard him lecture about 3 or 4 times, loved what he said, couldn't wait to get into orthopedics after that. I then, when I completed my residency, I went in the Army for 2 years, came back and joined Dr. David Sutherland at the Shriner Hospital for Crippled Children in San Francisco at that time on 19th Avenue and Lawton. I ran the Gait analysis laboratory there for 15 years, during which time we evaluated each child that came in with a gait problem. And if they had a gait problem, we made movies of it. We got Lockheed Aircraft interested in a project of trying to quantify gait. And John Hagee is the engineer that came up from Lockheed to the Shriner Hospital. And he and I worked there together in the Gait lab for 15 years until Nike liked what he did so much, they hired him away from Shriners Hospital. He also set up Gait laboratories in Boston and in Portland, Oregon. at the Nike headquarters there. So this material that I'm presenting today was made 40 years ago. You have to keep in mind that 40 years ago, there was no video. It was all done by film. And the film was taken at 200 to 400 frames a second in order to slow down Gait so you can see it. So with that in mind, let's look at the biomechanics of Gait. If we're going to talk about biomechanics, we need to look at the Gait cycle. The Gait cycle is 100%. 60% of it is stance phase, roughly 40% of it is swing phase. We divide the stance phase up into double limb support, a period of single limb support, and then the next period of double limb support, and then we go into the swing phase. You always have one foot on the ground. Now, when you look at running, that's a different story. You develop a float phase because the foot's off the ground. But today we're only going to talk about walking. If we look at this in a little more detail, heel strike occurs at 0%, foot flat is at 7%, opposite toe off occurs by 12% of the cycle. At 34%, heel off will begin. Opposite heel strike occurs at 50%. At 62%, we see toe off occurring, and then heel strike again ending the Gait cycle. So this is our person walking. So heel strike begins our Gait cycle. So this is heel strike at 0%. Nuts. Here we go. Notice the way as we walk, we sort of stretch our leg out. We're sort of pulling ourselves through space. We're not pushing ourselves forward with our foot. Sorry, this is. So heel strike. You see at heel strike, the way our knee flexes slightly. And at 34% of the cycle is when the opposite heel, as the leg swings by the stance foot, the heel starts to rise off the ground. Now, during this time, weight bearing, you can measure the pressures in the bottom of the foot. And this demonstrates the difference between adults and children. Obviously, much more force in an adult than in a child. This is the work of Peter Cavanaugh, and using a very sophisticated force plate system, he demonstrates very well the weight bearing on the bottom of the foot. Along the side is the Gait's stance phase in milliseconds. Your foot's on the ground for roughly 600 milliseconds, and then it's in the swing phase. So we note that at 32 milliseconds at heel strike, the buildup of pressure under the heel at roughly 12% of the cycle, which is 128 milliseconds. Notice how quickly the pressure moves from the heel. We start to load the metatarsal area. By roughly 224 seconds out, milliseconds, we get pressure underneath the metatarsal area. And by roughly 32% of the cycle, the pressure is building up under the metatarsal head. The heel is off the ground by this time. We begin to see the pressure building up now under the metatarsal heads. It passes out to the toes. And at 52% of the cycle, as we're up on our toes, we see that that's where all the pressure is located. And then at roughly 60% of the cycle, the pressure is leaving the toes completely. So here we are at heel strike. Sorry. So this is equivalent now to your pressure on the heel and hitting the ground. 12% of the cycle, you're at foot flat. At 22%, the other leg swings by, and at 34%, we're building up the pressure on the metatarsal head area. That continues to build through 52% of the cycle. You see a transfer of pressure to the toes, and by 62% is toe off. So at heel strike, we see maximum pressure in the heel area. 12% is foot flat. 22% the pressure now is along the bottom of the foot. And then 34% is the opposite foot swings by. The pressure is building underneath the metatarsal head. And that continues until the time of toe off. So let's look at the mechanics of the foot and what's happening. At heel strike, the foot is flexible. At toe off, the foot is rigid. And the rest of my talk is going to be how we create a rigid foot from this flexible foot as it hits the ground. In other words, you don't know what the foot doesn't know what the environment is going to be as it strikes the ground, so it needs to be flexible to adapt to it. At toe off, we're moving the body forward, so you want a rigid structure. So let's look at heel contact again. You can see the compression of the heel pad, and watch the way as the foot comes off on this side, you'll see inversion of the heel occurring. See the heel inverting there? And then again, you see the way the toes are literally lifted off the ground. They're not propelling us forward. So let's see what's happening during this period of time. What we have at initial ground contact is impact absorption, which is a passive mechanism. And this is a picture taken from Serafian's book on anatomy of the foot and ankle. What we're looking at is the head of the talus here, the end of the calcaneus here. So this is a transverse tarsal joint. And as our foot hits the ground, our calcaneus goes into eversion or valgus. And that's what we're seeing right here. The calcaneus moves out from underneath the talus. So the events that are occurring at heel strike are all passive. Your heel strikes the ground, the calcaneus everts, that's a passive mechanism. The transverse tarsal joint unlocks, the tibia and the lower extremity internally rotate, and the ankle joint plantar flexes. So at heel strike, the calcaneus moves from this position underneath the head of the talus to a position of valgus. And that's what we're seeing right here. You can see the way this moves out, and this unlocks the transverse tarsal joint. So at heel strike, the calcaneus everts, secondary to the weight bearing, and this causes inward rotation of the tibia. This is a model that was made by Vern Inman at the Biomechanics lab at UC. And basically what it's showing is the fact at the time of heel strike, the calcaneus goes out into eversion. This allows the longitudinal arch to collapse, and the tibia internally rotates. And this is what it looks like with the foot superimposed over it. So this is an energy absorption mechanism. So as the heel goes out, the tibia inverts, internally rotates rather. Now, proximally, what we see is that we see inward rotation of the tibia at heel strike, and distally, it unlocks the transverse tarsal joint, as we just looked at. So mechanics of the foot in the sagittal plane and the transverse plane. We'll look at each one. In the sagittal plane mechanics, we have four events here. The plantar aponeurosis, the intrinsic muscles of the foot, the configuration of the talonavicular joint, and ankle joint motion. The windlass mechanism plantar flexes the metatarsus. It inverts the calcaneus and transfers pressure to the toes at the time of toe off. The plantar aponeurosis starts at the heel, passes forward, and inserts into the base of the proximal phalanx through the plantar plate. And the tendons pass through little arcades in this area. So as the toes dorsiflex, what we see is this is wrapped around the metatarsal head, and that's stabilizing the longitudinal arch. So if we look at the windlass mechanism, if you look at these three dots, what we see is the fact when we dorsiflex our toes, this elevates the arch. You can see the way the arch is elevated there. And the calcaneus inverts. So looking at it live, or sort of live, if you notice these three dots here, as the toe gets dorsiflexed, you'll see this as it drags the plantar aponeurosis over the metatarsal heads, it raises the longitudinal arch. So this is strictly a passive mechanism. So as our foot hits the ground and we come over the ball of the foot, this is one of the mechanisms that stabilizes our longitudinal arch. The plantar aponeurosis is not put there just to be released because of heel pain. So normal weight bearing depends upon the proper function of the windlass mechanism to depress the metatarsal heads and transfer weight to the toes. So this unloads the metatarsal heads. So further stabilization of the longitudinal arch is, besides the plantar aponeurosis, is the transverse tarsal joint, the intrinsic muscles, and the talonavicular joint. So as the longitudinal arch is stabilized, it elevates. The next thing that happens is as we come up on the ball of our foot, the talus is pushed into the navicular. And if you look at the talus in more detail, we see that in the AP view, we have an arc that's larger than in the lateral view. This creates an elliptical paraboloid situation so that the more pressure that's applied, the more stability we get in our talonavicular joint. Now, let's see what happens at the ankle joint as we're walking. What we see at the time of initial ground contact is plantar flexion of the ankle. Anything going down on this graph is plantar flexion. Anything going up is dorsiflexion. So you can see at the time of heel strike, we rapidly plantar flex, after which we see a period of progressive dorsiflexion occurring until roughly 40% of the cycle. And this is when plantar flexion of the ankle begins. Plantar flexion continues then through toe off, and then we see dorsiflexion during the swing phase. Now, if we look at the muscle function during this time, what we see is the gastrocsoleus group is active after we strike the ground. So roughly from this point until here, the gastrocsoleus is functional. But what's happening during this time? We're not plantar flexing, we're dorsiflexing. So what is occurring is the ankle is being stabilized by the gastrocsoleus. The forward movement of the tibia over the fixed ankle is what's happening through an eccentric contraction of the gastrocsoleus muscle. Now, your tibialis anterior, the muscles in the front of the tibia, are functional also. As you can see, they become functional just prior to toe off in order to help bring about dorsiflexion during the swing phase. And they're active. This is through by a contraction, a concentric contraction, shortening. Over here, it's still active at the time of heel strike, allowing the foot to come down on the ground. This is an eccentric contraction. So that's what controls the ankle joint. So looking at the movie, what we see here is this is neutral. This is plantar flexion, dorsiflexion, plantar flexion, and toe off. So you'll note at the time of heel strike how rapidly we plantar flex and get into foot flat. We then see progressive dorsiflexion occurring during this phase. And this is all brought about, is controlled by your gastrocsoleus undergoing a lengthening or an eccentric contraction. The rapid plantar flexion at initial ground contact is controlled by the tibialis anterior muscle. We now see progressive dorsiflexion under the control of the gastrocsoleus undergoing an eccentric or lengthening contraction. Now, if we look at the forces across the ankle joint, it's very interesting. What we have here is force in percent of body weight. Along the bottom, we have percent of stance space now, not the entire cycle, just the time the foot's on the ground. And what you'll notice is when plantar flexion begins, which is about 70% of stance space, this is when you have the maximum stress across an ankle joint. And you can see that stress is about 4.5 times body weight, much more than any other joint in the body. Your knee only has about 2.5 times body weight. Now, this is with walking. If you're jogging or running, this increases by roughly 2.5 times more. So you have about 8 times body weight of force across an ankle joint as you're running. That's why little arthritis goes a long way towards messing up your gait. And if we look at this now, what we see is this is when you have maximum force on your ankle joint. Just after you start to plantar flex, this is when the stress builds across the ankle to about 2.5 times body weight. Now, we also have events occurring in the transverse plane. We look at the sagittal plane. Now, in the transverse plane, what we have is we have tibial rotation occurring. We have subtalar joint inversion and eversion, and the transverse tarsal joint is locking and unlocking. In the transverse plane, the magnitude of rotation is related to the shape of the articulations, their joint axis, and the ligamentous stability of the foot. You see when you've examined people's feet, some people are loose jointed, some people are tight jointed. And this is what determines how much rotation they get as they walk. So in the transverse plane, the tibial rotation at heel strike, we see inward rotation of the tibia. At foot flat, you have maximum inward rotation, and then outward rotation begins. At the time of toe off, we have maximum outward rotation, and in swing phase is outward rotation. This is work that was taken from the Biomechanics lab at UC under the direction of Vern Inman. It was interesting, UC and the Department of Engineering at UC Berkeley was granted a large sum of money to study gait after World War II, because there were a lot of amputees and they're looking for data as to how best to build prostheses. Interestingly, the chairman of the Department of Engineering in Berkeley had his leg amputated by Vern Inman in World War II. So they were sort of obliquely close friends and worked together on this project that was carried out mainly in Berkeley, but part of it at the Biomechanics lab at UC. So what we see here is everything going down on this graph is outward rotation. Anything going up is inward rotation, as you see here. So at the time of initial ground contact, everything is internally rotating, reaching a peak at the time of foot flat. We then see progressive external rotation occurring until the time of toe off, when internal rotation once again begins. So at foot flat, we have maximum internal rotation. As we start to plantar flex the ankle, we start to see outward rotation starting. And this film, it illustrates it quite nicely. We have this stick, which we held on with Velcro. Interestingly, in the study that was done at the engineering school in Berkeley, these guys drilled diamond pins into the tibias, and that's how they measured it using high-speed movies, which there are several pictures that I don't know, I'm probably floating around in the archives there, that show these guys, a couple of them actually used the drill to put their own pin in their tibia so they could measure it. That's real science. So anyway, watch the stick, what it does as your foot hits the ground. We see the way you get internal rotation of the tibia? That's in response to the collapse of the heel. nuts. Sorry, what happens? This is a new computer and it doesn't work the way my old one did. But anyway, what you see here is the fact that when the heel strikes the ground, watch that tibial stick. See the way it reaches maximum inversion? So this is what happens as we strike the ground. So if you look at it from a clinical standpoint, how do you decrease that? Well, if you put a lift on the inner side of the shoe, that'll diminish some of that rotation. So this demonstrates the motion we just seen. So the rotation that we're seeing passes across the ankle joint. There's no transverse rotation in the ankle joint. I shouldn't say there's none, there is a little bit. And this is transmitted by the subtalar joint to the transverse tarsal joint. And again, a model made by Dr. Inman shows that the subtalar joint functions like a 45-degree hinge, transferring the motion between the tibia to the calcaneus and into the foot. So the time we hit the ground, our heel goes out into eversion, the tibia internally rotates. And the time of toe off, we see external rotation of the tibia with inversion of the calcaneus. The axis of the subtalar joint passes from medial to lateral at about 23 degrees. In the sagittal plane, it's at about 41 degrees, but you can see there's a great deal of variation in the axis of the subtalar joint. This was a study, again, done at UC by an orthopedic resident named Gib Wright. He was in Sacramento, and also Desai, who was an engineering student. So the rotation of the subtalar joint is interesting. Anything going up in this graph is inversion. Anything going down is eversion. So what we note at the time of heel strike is that we see eversion, valgus, occurring in the subtalar joint, reaches a maximum at the time of foot flat, and sort of stays there until we start to load our foot again at nearing toe off. So what we see is the fact that at about 40% of the cycle, we start to see inversion occurring in a normal foot. A person with a flat foot now, you see inversion occurring over a longer period of time. And that continues till toe off. And after toe off, the subtalar joint just sort of flops around in space. If we look at the intrinsic muscles of the foot, we see that it's interesting because their period of activity is less in a normal foot than it is in a flat foot. And a normal foot becomes active at about 30% of the cycle until the time of toe off. In a flat-footed person, becomes active at about 15% of the cycle until the time of toe off. This is work done at the Biomechanics lab at UC. I did this study on the intrinsic muscles of the foot when I was a resident. It was interesting as a sidelight. Dr. Inman knew the people on the board at the journal, And I was in his office one day and he phoned up this fellow Thornton, who was the editor of the journal at the time. And his nickname was Thorny. And he said, "Thorny, I have a good paper I think you're going to like." So he sent the paper back to him and it was accepted. And it was a lead article which is the first article I ever published on motion of the function of the intrinsic muscles of the foot. A lot of water under the bridge since then. So what we're seeing now, again, another model of Dr. Inman's, and what he showed was with eversion of the calcaneus, which is what happens when we strike the ground, we get internal rotation of the tibia. And at the time of toe off, where we have external rotation of the tibia, this is associated with internal rotation of the heel. Now we add the transverse tarsal joint is the next joint in this linkage. So we have our subtalar joint. Next forward is this transverse tarsal joint, the talonavicular calcaneo cuboid joint. And what's happening is the rotation of the calcaneus will affect and stabilize the transverse tarsal joint. As we strike the ground, the heel is out in valgus, unlocking that joint. At the time of toe off, it's inverted, which locks the transverse tarsal joint. This was work that was done by Elfman, who actually lived in Marin County at the time. What you're looking at is the head of the talus and the head of the calcaneus. When the joint is in neutral position, the talonavicular joint and calcaneo cuboid joint axis line up, creating a flexible joint. This is what happens at the time of initial ground contact. At the time of toe off now, we see that these joints are no longer parallel, but rather incongruent. And this creates more rigidity to the calcaneo cuboid joint. This is a model taken from Serafian's book. And what you see is the head of the talus and the calcaneus. So at heel strike, the calcaneus moves out from under the head of the talus into valgus, unlocking the transverse tarsal joint. We notice at the time of toe off, here's the head of the talus. We see the calcaneus has moved back underneath this, creating stability to the transverse tarsal joint. So the events at toe off are dynamic compared to what we saw at the events at heel strike. What we note here is the fact that the lower extremity and tibia externally rotate, the subtalar joint inverts, that's locking the transverse tarsal joint. The plantar aponeurosis is stabilizing the first MTP joint, and then talonavicular joint is stabilized as the surface of the two joints are squeezed together. So again, what we're seeing here at the time of toe off, at the time of heel strike, we have the calcaneus moves away from underneath the talus. At the time of toe off, we see the talus is now being supported by the calcaneus. And again, one of Dr. Inman's models demonstrating that with external rotation of the tibia, as we saw in the graph in the movie, we get inversion of the heel and flattening, rather not flattening, we have elevation of the longitudinal arch. And again, in superimposing the foot over this, you can see that inversion of the internal rotation of the heel brings about this rotation of the foot. At toe off, the external rotation is enhanced by the plantar aponeurosis and the transverse metatarsal break.
I mean, it's like the same pictures from our textbook. What's that?
The transverse metatarsal break is the oblique line drawn along the metatarsal heads. If you look down at your shoe, if anybody has a leather shoe anymore, you'll see that oblique line across the shoe. That's the metatarsal break. And if we look at the axis now of the foot and ankle compared to the muscles, it's interesting. We have our subtalar axis, remember, move from medial to lateral at about 16 degrees. And then crossing that, we have our ankle axis. So any muscle anterior to the ankle axis will bring about dorsiflexion. Anything posterior bring about plantar flexion. Anything medial to the subtalar axis will bring about eversion, and anything medial to it can bring about inversion. So putting our muscles around this, what we see is the fact that our Achilles tendon inserting medial to the subtalar axis is an inverter of the heel. You can see how far it is from the ankle axis. It's a very strong plantar flex of the ankle. Then here are the posterior tib, and the other muscles are all inverters and also plantar flexors, but not with the magnitude of the Achilles tendon. The peroneals are on the lateral side, so they're everters, but they're still posterior to the ankle, and they bring about plantar flexion. Anything anterior to the ankle axis brings about dorsiflex. We have the anterior tib, and we have the extensor tendons. You can see the anterior tib sort of sits on the subtalar axis. It's not a strong inverter or everter of the axis. So basically what I've done today is covered the biomechanics of the foot as we strike the ground. This is the view from where I'm sitting. I can look over the whole Bay Area. You guys are over here someplace. See the Golden Gate Bridge, the Bay Bridge, the port loading and unloading. So this is what I've done. I love Gait. Used to look at it a lot. We made this movie when I was at the Shriner Hospital, and it's old. The movie's roughly 40 years old. The film started to fade. I was lucky to be able to get some old film that wasn't too badly faded and put on video. And so that's what we've done. So anyway, that's what happens with Gait. And if you'd like to ask questions, I'd be glad to try to answer them.
Great. Thank you, Dr. Mann. That was great, and so much wisdom and insight on the topic. We really appreciate it. And we could open up to any questions, comments. I see a hand up from Dr. Lotes, so we'll start there.
Thank you, Drew. Thank you, Dr. Mann, for an inspiring presentation. As we've been working with more and more new technologies that make measurements from Gait accessible in the clinic, the dilemma we face now is how to collapse these measurements into values that have clinical meaning for decision making. And I'm curious if you have any suggestions for us as to how do we bring all of this knowledge to the point of care that helps clinicians make decisions.
Well, that's actually a very good question. When we started this studies at Shriner Hospital, like I say, the engineers came up from Lockheed and created all the programs that we needed in order to analyze the gaits, each gait cycle. It would, at that time, now this is before you had computers, so we're going way back in time. And in order to analyze one step, it took our engineer all day using a big adding machine to calculate all the tangents and cosines and everything in order to create a graph of each one of these movements. So we then created for each patient a graph of their motions to the lower extremity. I got to know Jackie Perry very well at Rancho Los Amigos, and about every 3 months we would go down there with the film we had taken of children with various gait problems to discuss it with her and also show her the graphs that we made. And she liked it. She said, it takes too long. You can't use it in a clinical setting. Well, fortunately, computers came about. It's now done, they print it out instantly. So that's how you can do it. And we would have graphs of each joint, and you'd print out ankle motion, knee motion, hip motion. And so it's doable. And we had them in the charts at the Shriner Hospital at that time. And it takes some education of the doctors because they're not used to looking at it. But what we used to do is we would analyze the children preoperatively and postoperatively, and then see them back 5 years later, 1 year later, and to see whether or not the surgery that was suggested worked. Looking at kids with cerebral palsy is very difficult. And in the clinical charts, everyone will say, oh yeah, the patient got better. Well, you look at the films and you say, oh no, the patient didn't get better. They started at a crouch, they went through surgery, all the physical therapy, they look good at a year, 2 years, they're back halfway there. By 3 or 4 years, they're back down their crouches again. So it was, it's very instructional to have longitudinal film. I unfortunately lost most of it when Shriners pulled up stakes and moved to Sacramento. But that's how you can use it. You have to have it all computerized, and now it's a piece of cake. They do computerized.
Thank you.
See, Dr. Vale.
Hello, Roger. Tad Vale here. Thank you for a great presentation, and I'm delighted that we have it recorded. And I hope the residents will watch it over and over and over again and understand these fundamental concepts of the lower extremity mechanics. I'm struck by the simplicity and the elegance of the drawings and your description of how it works. Likewise, Jackie Perry in her book has some beautiful drawings and renditions of similar concepts. And I would also say, if you have pictures of the early days with Vern Inman, we should copy those and post them, just as historical for within the department. If there's anything in your archive that you would share along those lines, and then I just want to say and get your reaction in sort of response to Jeff. When I look at these as a hip and knee surgeon, there's so much relevance how gait works. For example, the impact of weak gluteal muscles on femoral rotation, then tibial rotation, and subsequently valgus of the foot. Things like that, where there's clear clinical implication to understanding the relationships between the rotation and the position of the lower extremity that I've used in my practice often. And I get patients out of the room and make them walk down the hall. And I'm assuming you do the same with frequency.
Yeah, it's all one big package is what it is. I mean, what happens down on the foot is translated all the way up to the hip. There's no doubt about that. And I think you can influence it by wedges and things like that in the shoe will help change some of the rotation. And I think from what we saw today, you can see the way that works. You understand that tibial stick, which you see as your foot hits the ground internally rotating, if you had a lift along the medial side of the shoe, that would diminish that. So these are things certainly that has very much clinical relevance, and it's fun to do. It's fun to sit around and look at movies of patients walking and try to analyze what we're seeing. And at least now we can quantify it, which makes it easier.
Yeah, fantastic. Thank you. Thank you so much.
You're welcome.
Hi, Roger. Kirsty here. I just wanted to thank you for all of your contributions. I think you're just such a true inspiration to all of us. especially with your dedication and commitment to developing the foot and ankle subsection of orthopedics is really kind of astounding and admirable. So I agreed with Rick. You're definitely the goat of foot and ankle surgery. But my question to you, after listening to some of your slides, what I get asked by a lot of my friends and family and patients, after all of your analyses of these kids, how do you advise parents and people of kids that have, I just wanted to know how do you advise them with the regarding the concept of orthotics? If a child comes in with a painless flat foot, do you think they need orthotics? Do you think it even makes a difference? And that kind of leads me to my second question regarding your adult patient population. In general, do you think people need customized orthotics? Do you think over-the-counter orthotics are adequate? Do you think people need orthotics at all? It's just, I'd be interested to hear your thoughts after looking at all these Gait analyses and all these force plate analyses, what your thoughts are and how you would advise kids as well as adult patients. Thanks.
Well, you're welcome. That's a good question too. It's a there's a whole group of people grew up prescribing orthotic devices for people. Most people don't need them. In other words, the foot's been going on for a long time. We never had an orthotics early on, and they really don't add anything. You do have the occasional patient that needs an orthotic device. In adults, you need them in order to, say, relieve pressure on the metatarsal heads because of atrophy, the plantar fat pad, calluses, different things like that. But the average person does not need an orthotic device. In fact, the softer the insole in the shoe, the better off you are, rather than a hard plastic liner. So kiddies don't need it. Kiddies all have flat feet, and they all grew up with an arch. You don't have to influence them with arch supports. So I'm not a big fan of arch supports. In my practice, I rarely use them. There's a product called HAPAD, H-A-P-A-D, and those are little pads you can put in patients' shoes that takes pressure off of areas, and it works just as well as any arch support. They're cheap. You can put it in the clinic in their shoe. They say, "Oh, that feels better," and you tell them where they can buy them and put them in their other shoes. So I am not a big fan of orthotic devices.
Great, appreciate that. And we use the HAPAD as well. We have a catalogs that we give, pamphlets that we give out to patients as well. So I think we're on the same page.
Any other thoughts or comments?
Hi, Drew. I'm sorry, I'm driving. This is Sanjeev Sabharwal from Ortho. Dr. Mann, it's really a pleasure and an honor to hear you speak and realize that your background was in pediatrics, so that's great. I just have a question about, tibialis anterior. Like you pointed out, it's really neither an inverter nor an everter. And yet, we do a fair amount of tib band transfers for dynamic club feet in kids. What are your thoughts on doing a tib band transfer in a kid with a supple dynamic club foot who's got sort of dynamic inversion?
You said in a club foot?
Yeah, well, so we see children with residual club feet who sometimes have dynamic supination in the swing phase of gait. And, it's one of those, like a Ponseti, thinking that you take the tip end and move it laterally, usually to the lateral cuneiform, in order to sort of balance the foot. And knowing that the tib band is really in line with the subtalar axis, I mean, anatomically, it doesn't make too much sense to me, and yet it works clinically. I just wanted to know your thoughts on that.
Well, the axis of the subtalar joint is kind of all screwed up in a club foot. In other words, it's not where it is in a normal foot. So I think that moving the tib band in a kid that has um, a flat foot or following a procedure for a club foot is a reasonable thing to do. You don't want to move it too far laterally because that's going to cause more of a flat foot. You have to look at the child very carefully, try to get a good feel as to how much pull the tib ant is making to deform the foot, and then move it accordingly. I mean, sometimes you can split it and just move half of it over. That would work. But each child or each patient, you have to analyze the foot in your hands, see where it is, and move it accordingly. I don't move many anterior tibial tendons, but conversely, I don't see many kids anymore either.
Great, thank you.
All right, I think we're just about at time, so I think we will wrap up there. But Dr. Mann, thank you again so much for joining us and for excellent talk, very educational, and then also thank you for all of your contributions. Thank you all for joining, and we will be back next week with Dr. Alicia Fernandez.
Thank you.